Okay, hello, good afternoon, everybody. I'm really honored to have this opportunity to speak today. My name is Jane Clougherty. I'm an associate professor. I'm very happy to be here at Drexel, Dornsife School of Public Health. So the work I'm going to be speaking about today really focuses around the idea of social susceptibility to a physical exposure, that is air pollution, which differs both across communities within urban areas and over time. And let's start with the obvious. Urban health is really, really complicated. As we've heard today, there are many factors and many different exposures and facets of communities that act together to shape population health within urban settings. And what my lab is focused on doing is really thinking about the portion of this that might be explained by air pollution exposures and the combination of air pollution exposures with social and really psychosocial stress factors. So we're thinking about two very different types of exposures. Some are physical, some are social, and how they might play together in helping us understand patterns of health across urban communities. So why might we be doing this? Well, first of all, there's a lot of literature linking both air pollution exposures to a number of different important health outcomes, including respiratory and cardiovascular diseases. And likewise, there's a lot of literature linking stress and social exposures to these same outcomes. One of the interesting facets of research in air pollution epidemiology in recent years is that there's growing evidence that air pollution affects not only the exposures may be higher in lower income communities or lower SEP, socioeconomic position communities, but susceptibility to those exposures may be greater. So therefore, the same pollution exposure may have greater impact in a lower SEP community. But we really have no idea why that is. There are many facets and many different exposures that are associated with socioeconomic position in our country as well as in other countries. But there is a really huge body of evidence looking at the effect of chronic stress on health broadly. So stress is well known to impact a wide number of regulatory systems throughout the body. Almost pick your health outcome, and stress is related to it, both acute and chronic stress. So it stands to reason that if stress has so much to do with our underlying susceptibility, then maybe it's really impacting how resilient we are to every other physical exposure that we encounter. So that's really what we're thinking about when we're doing these large-scale epidemiology studies. But one of the challenging things about studying stress is that it really, truly is in the eye of the beholder. So something that is stressful to one person is not stressful to another. And I always use the example of divorce to explain this. So there are probably people you know who think that their divorce is the worst thing they ever went through. And you probably also know people who think that their divorce is the single greatest thing that ever happened to them. Okay? So stress is entirely in the eye of the beholder. However, when I'm doing an epidemiology study where I have over 1 million people in my data set, I can't interview everybody. So the gold standard for stress really is questionnaire-based individual perceived measures, but we can't always get them. And that's the challenge. So for these large studies, I'm going to show you a couple of results from some of our studies in New York City today. We went into GIS, as we often do, as a first step, and kind of dug for anything and everything available to help us understand differences in exposures to stressors. Those are things that may be perceived as stressful across different communities in New York. And what we found were a huge suite of measures available. New York is very data rich. It's one of the reasons why it's an excellent place to do urban health research. We looked at indicators of crime and violence exposures, built environment indicators, access to health care, noise disruption indicators, child-specific stressors. These are things like school-based indicators, percent of kids in schools that are overcrowded, for example, and indicators of socioeconomic position. But then, of course, we're left with the question of which of these is right. Which of these best proxies for stress, or what combination thereof best proxies for stress when we're trying to do an epi study across 1 million different people scattered across New York City? So it's a real challenge. I'll show you in a moment one of the ways that we attacked that question. The other thing I'm going to point out when we're using administrative data for epidemiology research, because this is a session about data, is that all of these different metrics were collected by different city agencies. The police department uses police precincts. The schools department uses school districts. The community health survey uses community districts. Health data is aggregated at the United Health Fund area. Census data is at the census tract, and I could go on. Which, of course, in GIS leaves us with all of these problems about how on earth we put all of these disparate areas together and make sense of a puzzle where the pieces don't really line up. Okay. So, by way of first thinking about what are the right stressors, what are the right indicators we should be using, we did two things. The first was to run out and implement a whole bunch of focus groups across the city where we asked people, what are the important stressors in your community? And let them tell us, to make sure we had the right list and we weren't missing anything major. And we kind of expected to hear very different stressors coming up in very different parts of the city. And this is roughly the rank order list on the left of what we heard in our focus groups. The ones on the top were discussed by most of the focus groups and then fewer as we go down. The only topic that came up in every single focus group we did was crime and violence. You'll hear that theme again. No matter where we went in New York, that's what people wanted to talk about. And then they started talking about things like rats and gentrification and all kinds of other important things. But that was sort of the first and foremost thing that came up all the time. And then the next thing we had to do was to match this up with all of that great GIS data that I just showed you on the prior slide. And of course, sometimes we have measures that reasonably line up, but oftentimes we just don't. And that's one of the big problems with GIS data, is we don't always have the measures we need when we want them. But we all know we don't always have the perfect data. We have to make do with what we can get. The second thing that we did was we ran a whole bunch of surveys, individual level surveys, spatially distributed citywide, and we asked people, where do you live? That is the nearest cross streets to their home for anonymity. And are you stressed? And this was our opportunity to link the aggregate level aerial stressor indicator, such as a violent crime rate or a poverty rate, with the individual level perceived stress metric to validate that we were actually getting something meaningful to individuals that actually reasonably proxied for stress. And what you'll see here is for a 1 IQR increase in area assault rate, so we're going from the 25th to the 75th percentile communities in assault rate, you'll see that individuals had twice the odds of reporting a perceived lack of safety in their community, twice the odds of reporting perceived high crime, but no elevated odds of reporting a personal experience of violence in their community. So what's really important about this is that we were getting at something that was about context rather than composition. So we were actually getting at something about the experience of living in these communities and the experience of feeling unsafe versus a composite aggregation effect of individual level experiences necessarily. So it's a really important distinction when we're interpreting these community level metrics. So I'll show you one of our epidemiology studies where we tried to kind of put this data together with air pollution data and try to make sense of the interaction among those. Okay? So the data I'm going to be showing you is emergency department data that we obtained from SPARCS, which is the New York State Department of Health Statewide Planning and Research Cooperative System. Say that 3 times quickly. It includes 1.1 million cardiovascular events that came into the New York City emergency departments between 2005 and 2011. The air pollution data that we use is fine-scale 100-meter air pollution surfaces that were produced back when I worked at New York City Department of Health and Mental Hygiene. This was sort of the mega air pollution study where we monitored a number of different pollutants year-round for 2 years at 155 sites, and we're able to build very fine-scale 100-meter spatial models for pollution that we're still churning in epidemiology today. And we combine that with EPA regulatory data so that we can get day and location-specific exposure estimates for all 1.1 million people in our data set for fine particles, nitrogen dioxide, sulfur dioxide, and ozone. We apply this using conditional logistic regression in a case crossover design. As most of you know, but I'll say it anyway, case crossover, we're basically comparing people to themselves. So you're looking at air pollution on a given day and that individual's likelihood of having a cardiovascular event with, say, air pollution on the 2 Mondays prior and the 2 Mondays after in June of the same year. So we're effectively looking at short-term changes in air pollution, space and time specific, against likelihoods of cardiovascular events. But by nature of using this method, we're inherently controlling for individual non-time varying characteristics, things like age or sex or race, which is both a plus, because we're taking a lot of confounding out of the way, but also a minus, because we're losing some really important determinants of health when we do that. So the interpretation we always need to be careful about. Okay. We geocode everybody in our data set using 3 different methods, and I'm going to credit Ellen Kinney, who is right there, who's the geodata manager for my lab. God bless her. I don't know how she does it. But once we've done that and Ellen's determined the most precision we can possibly get in our geocoding, we create exposures usually for the 300 meters around the home. We adjust for a number of different covariates, and then we look for effect modification by a number of different stressors, as I described previously. And this is what we saw in this study. Looking at NO2, fine particles, SO2, and ozone, we see same-day effects. So looking across lag days 0 through 6, so that's case day or event day, up to 6 days prior, we see these very short-term acute effects of air pollution on CVD, and that is consistent with the literature. Pete DiCarlo pointed out earlier that ozone is the secondary pollutant, and we actually get our highest concentrations of ozone in the outer parts of the city and downwind. In fact, that is exactly what we see in our data set as well, and that's why you see some protective effects on ozone. Okay, and then when we start thinking about effect modification, we saw what you might expect to see. When we look across tertiles of violent crime for NO2, we see stronger effects of NO2 on CVD in communities in the medium and high tertiles of violent crime relative to the low crime reference group. And this effect holds up when we look at assault rate, poverty rate, or an index of socioeconomic deprivation. And those are the NO2 effects where we saw the strongest effects, but likewise we see this for PM and SO2 as well in the hypothesized direction. But we're back to our familiar question, would the real stressor please stand up? Okay, these are very, very highly spatially correlated maps of the 4 stressors that we just looked at modification by. So how on earth do we tear them apart? Well, in a separate study, we actually dove in and tried to separate the effects of community assault rate or violent crime from effects of community poverty on modifying ozone effects on asthma. And in that case, what we found is that we did see, in all cases, the lowest risk of ozone in our low crime, low deprivation communities. Those are the circles there. Our highest risks were consistently in communities that were marked by high crime, but relatively low levels of poverty, rather than in communities with lower crime, but higher poverty. And so it's a little bit of an awkward interpretation here, but when we ran multiple modifier models and other methods, we tried 3 or 4 different methods, and no matter what we did, the violence effects were stronger than the poverty effects, at least for asthma. So that was a really interesting finding in that study, and that paper was just accepted. Perry Sheffield, our colleague from Mount Sinai, who will be here tomorrow, was the first author on that paper. Okay, so this means we have to dig in even further on violent crime in New York, because there appears to be something really strong going on there in terms of susceptibility. So we have, thank goodness, gotten our grubby little paws on NYPD databases. So we're now working with point-level NYPD data, which is day and location specific, rather than police precinct annual averages. So you can see the difference there in the resolution off the bat, and likewise we'll be able to get into time-space modeling for violence rather than working with overall area averages. This is one of the really critical differences that I'd like to point out, as we are again a data session, is that oftentimes for air pollution exposures, and likewise for temperature as well and many other physical exposures, we have day and location specific exposure information, and oftentimes for the social exposures, we're working with census data or big annual averages at big tracts, and we have to think about all the resolution we lose in that. Okay, the other big thing that we learned in our data set is there is actually a 14-year difference in the median age at CVD event between Black and white New Yorkers. And when we're looking at case crossover models, we're focused on day-to-day changes in pollution exposures and susceptibility. But the real action is probably up here at the order of years. So one of the big questions that I wanted to raise today is how our methods may actually be driving the questions that we ask and why we want to be careful about that. Because if we're using methods that focus on short time scale exposures, we may be missing a lot of those big processes that are driving risk over time. The other thing that I'm going to add as we're thinking about community level exposures is that New York, like most American cities, is very, very racially segregated. And if you don't believe me, this is a histogram of percent Black and percent white across all 2,000 census tracts in New York City. So the vast majority of census tracts are almost entirely or majority Black or majority white. There are very, very, very few truly mixed census tracts. So when we're trying to think about the effect of community level exposures separate from individual level characteristics, there's a lot of inherent confounding in there because we just don't have the crossover that we wish we had in epidemiological terms to look at the effects of different types of individuals living in different types of communities. Okay, so I'll go ahead and wrap up. GIS is an incredibly powerful tool. We use it every day, but we need to understand what these metrics do and do not capture and be careful in our interpretations. We do observe short-term effects of PM, NO2, and SO2 on CVD risk. It's stronger in communities with higher stressor exposures. We see some suggestion from the asthma work that violence may be the predominant stressor, and that certainly resonates with what our focus groups were telling us. But of course, as always, more investigation is needed. And we saw these huge racial differences in age at CVD, which means we need to be thinking about long-term processes at the same time as we're thinking about short-term demonstrations of risk. In terms of what that means for urban health and data challenges, well, big data is fantastic, but we're often using data outside of its intended purposes or its intended applications. We need to be cautious about what it does and doesn't capture and make sure that we're aware of the inherent trends in that data that may be affecting what we see. So for example, differences in data entry by hospital will show up as spatial differences in our data set because different hospitals serve different communities. Okay? And likewise, when we're thinking about trying to capture something as complex as psychosocial stress in a relatively blunt or community-level GIS indicator, we need to be careful about what that is and isn't capturing. Of course, thinking about spatial correlation, autocorrelation in our data, effects of segregation, and as I mentioned, being careful that the methods we're using are not driving the questions that we ask, but we're actually asking useful and meaningful and applicable questions first, and then deriving the methods to serve those. Alrighty, so with that, I'm going to offer my great appreciation to all the people who've worked so hard on all of these studies, including the folks in my lab and all of our colleagues at our partner institutions, our funders, and thank you all for the invitation and your attention today.